is arguably one of the weirdest things I ever dealt with when I worked in EMS. Digoxin or Digitalis or Wabane, whatever you want to call it, is really frequently used to treat patients who have congestive heart failure. Because they've had a heart attack, they've had damage done to their heart, and it's not able to pump with as much veracity as it needed to, and so there's kind of this sluggish lag in the movement of blood. And the weirdest thing was that these patients they would complain of the weirdest freaking symptoms just from this thing. This thing would interact with the sodium-potassium pump. They would complain of seeing like people with like a orange or golden like rings around their bodies, and they would like sometimes even complain of seeing like green men and hallucinations. It was so weird. But anyways, the purpose of digoxin is it's a very good one example of showing how we can change membrane potentials and how we can interact with pumps. But how the hell they figured this out, I mean, I feel like so much of this is just trial and error. But what we're doing with digoxin or Digitalis is we're going to strengthen the heart contraction. We're going to strengthen the cardiomyocyte contraction. So let's look at what is happening to the resting membrane potential of the cell. So let's talk about, I'm going to show you, and this is just a sketch. No, this is not the specific details of it, but I'm just going to show you what would happen versus a normal one, a normal cardiomyocyte versus one that's under the influence of Digitalis or digoxin. So under normal conditions, right, it starts off, we have threshold is reached, all the sodium channels open, we have this rapid influx of sodium. Once we reach the positive millivoltage value, all potassium channels open, we have this rapid efflux of potassium coming out. A little bit of a hyper areas there where it dips down there and it comes back to normal. So that's the normal circumstances that we have here. You already know this, right? So this is threshold, all the sodium channels are going to open up, all the sodium channels close, potassium channels open. I'm not going to draw that out here because that's not really important. But when we were under Digitalis, okay, when we're using Digitalis, we're going to strengthen the cardiomyocyte contraction. And what's so counterintuitive is that we're actually going to be inhibiting the sodium-potassium pump. What we observe is not like this, but rather something a little bit along the lines of this. I should have drawn that more of like a bell-shaped thing. But anyways, I think you're getting the point that it's wider, right? So what this is this is a stronger / wider, you can think about it, muscle contraction. And also, because of this, it's easier for us to reach thresholds. We're going to be able to reach the threshold value much, much faster than that of normal circumstances. So how does this work? Well, the way that this works is by blocking the sodium-potassium pump. So if we're blocking the sodium-potassium pump, we're blocking something that would normally result in us having a negative resting membrane potential. The sodium is going to stay inside. I'm just going to say it stays in the cell. So if this stays in the cell, then obviously we have a higher resting membrane potential. We're going to be able to reach a threshold value much faster. And also what's known is that calcium is going to stay in the cell longer as well. Now, I'm not saying that these things are permanently locked in the cell, otherwise we wouldn't be able to relax, but it's not an all or nothing phenomenon. It's just going to be staying in the cell longer, so I'm just going to say longer. For a longer period of time than that of what it would normally do this. So if calcium stays in the cell longer, then the ultimate results of this are that it's going to stay bound to the troponin, which interacts with tropomyosin, which leads to myosin and actin contraction. One of the biggest factors for aging, at least in skeletal muscle, not really so much I think is evidence to point to cardiac muscle, is over time there is a loss of calcium from the sarcoplasmic reticulum, and that's why muscles can't contract as strongly. So if we're able to do this, we're able to essentially make sure that the calcium stays in the cells longer, and therefore the contraction will, one, be stronger, but also the membrane potential, it's not going to have to work as hard to get this massive, strong contraction. And the way that this works, I guess I should have explained this part first, is that the calcium ions and the sodium ions, I should have said cations if I wanted to be really specific here, but anyways, under normal conditions, I'll just write this up here that this is the normal, calcium is going out of the cell, and sodium is going into the cell. So what would be the results of this normally is that if we have calcium leaving the cell, and I'm kind of ignoring potassium at this point because that's kind of not really relevant to our discussion. Nothing really changes with potassium. But normally we have calcium moving out and then sodium rushing in as a an antiporter, sorry. And as an antiporter there, this is also really a 2 versus 1. Well, this is going to result in the formation of a negative resting membrane potential as well. But the main thing is just this, is that if we're blocking the sodium-potassium pump, okay, then we're blocking the rate at which sodium is leaving the cell, and we're also, by extension, blocking the rate or decreasing the rate at which calcium is going to leave the cell. So that's how this works.